I'd now like to invite my colleagues from other Pan-Canadian health organizations to the stage, and I'm going to turn this next section over to Heather Logan, who will moderate.
Bonjour, après-midi ou soirée selon l'endroit où vous vous trouvez dans le monde tout de suite. Bienvenue au Symposium. Merci d'avoir pris le temps de vous joindre à nous. Good morning, good afternoon, or good evening from wherever you are joining us in the world. We have a very significant in-person and a very significant online presence today. Welcome to our symposium, and thank you for taking the time out of your day and choosing to come to our event. So you've heard about our focus, our objective for today. We have some of Canada's most significant health leaders from Pan-Canadian health organizations joining on the podium today, and it's an honor to be here with them, and it's an honor to be able to introduce them and spend time with them. We may run a few minutes late into the break. I apologize in advance. Those of you who know me know I will speak quickly, and I think they do too, so we'll try and limit how much time you have away from break. So, with introductions, to my immediate left, Michael Green is the President and CEO of Canada Health Infoway since 2014. Sorry, immediately over. Michael has been a very strong advocate for access to information, and in fact is driving a strategy to achieve that vision. I know you'll learn a lot from him, bold ideas. Suzanne in pink, hard to miss on the left, and you might think pink is the CADTH new color. It is not, we just are in fashion. Suzanne has a distinguished career as a clinician supporting patients. She was a registered nurse. Before coming to CADTH was the Executive Officer of the Ontario Drug Programs and also the ADM over Drugs and Devices Division in the Ontario Ministry of Health. David, to my left, is a strong advocate for access to data and evidence to support decision-making. You heard Deputy Minister Lucas talk today about indicators in health, and his organization is helping us to think through how to measure performance of the healthcare systems in Canada. As part of that February 7th Prime Minister's announcement, you can read more about those indicators. We'll talk a little bit about that today. And finally, Jennifer in blue, to Suzanne's right, is the inaugural President and CEO of Healthcare Excellence Canada, which you know was an amalgamation of two organizations in 2020, the Canadian Patient Safety Institute, so she brings that lens, as well as the Canadian Foundation for Healthcare Innovation, so finding opportunities to scale and to spread in the healthcare system. She has a history of firsts, and I invite you to read all of the biographies in your package. I'm going to ask two questions of each of our panelists in a particular order, and then we have a series of questions. I will invite those of you who are in the audience. There should be papers in the middle of your table. You can write questions. If you put your hand up, one of our lovely staff will come and pick them up and bring them to me. If you're online, Farah, if you could put your hand up and wave in the room. There she is. All of our online participants are invited to put questions in, and Farah will let me know if we have some online, and then we'll ask the panelists to respond to them. Finally, I hope you'll just join me for a minute in just thanking our fantastic event staff for bringing us together. It is so terrific to be in a room with people, have a chance to reconnect, build new partnerships, and get to know each other. Please take a minute and join me in welcoming them. Thank you, ma'am. Okay. So, question number one. Our future today is shaping future-ready health systems. Our panel is looking at a pan-Canadian approach with pan-Canadian health organizations. In 2018, Drs. PJ Foray and Daniel Martin presented the Fit for Purpose report. If you haven't read it, I invite you to do so. It raised questions about the impact and highlighted the pressing need for pan-Canadian health organizations to help citizens, providers, administrators, and policymakers address vulnerabilities of today's health systems. So I'm going to ask you in order, as you sit on the panel, what do you think has changed since 2018? How have your organizations responded to that report? And how do you find your working relationships between organizations across the country? Please, David first.
Thanks, Heather. And thank you for inviting CADTH to be part of this. We work closely with all of the organizations that are up on the podium. I'm looking forward to the discussion. So I think the directions that were set out in the Fit for Purpose report were simply amplified and accelerated by the fact of the pandemic, when we were forced to put aside our institutional egos, which we all have as the nature of our structures of our organizations, because the information that was required to inform rapid decision-making in key areas of policy and program design simply wasn't there. It's been surprising to me, for those folks who lived through it, which you all did, about how quickly the institutional memory of what it was like pre-pandemic, or pre-vaccination, like in those early months of the pandemic, how dramatic it costs on the Canadian sort of civil society of a very blunt instrument, which was quarantining people, was the only ways that we felt that we had any sort of sense of controlling the spread of the contagion. And there was no data to support, at the time, the kind of information-informed policy making that would have given a more precise ability to gather the information from the vaccination sites across the country, align it with what needed to happen. So what's happened, I think, is the absolute understanding that collaborative networks, adaptability, not making perfectionism the enemy of the effective action are things that have taken place. I don't think we've ever worked more closely together with our colleagues on this dais, but I've never seen either in the 6 months after the pandemic was announced the degree of collaboration between the federal and provincial governments and healthcare that I'd ever seen before.
Michael.
Yeah, I think building on that, our organizations are relatively small organizations in the scheme of the whole health system. But I think that our work together with the federal government helps to kind of bridge the gap between policy, communication, implementation within the provinces and territories. And I think as small organizations, what we can do is that we can help convene the provinces and territories together, and that we can play a big role in perhaps also, reducing duplication of effort across the board. And specifically, I think after the report and in the beginning of the pandemic, and I think we should also acknowledge the leadership of Health Canada, Stephen Lucas and his team and the Minister, in that I think they really do see the value that our organizations can help provide. And, definitely there's been a very big kind of concerted effort where there's much more coordination of our activities. I mean, we do many different things, but there are some core familiar points between each of the organizations, and I think Health Canada has helped to kind of convene that so that we can be more effective and amplify the effort and input that we can provide.
Thank you. And Jennifer, your organization, and you in particular, played a role in bringing pCHOs together. Can you speak about that?
Yeah, so I'll do a yes and, as if we were at improv, which I know we're not today. But if we go back to the Fit for Purpose report, it really had two main streams. There was a set of streams of how could we work better together with, to Michael's point, Health Canada as well. So how could we do things in the back end that would be supportive of better collaboration? And then there was a set of structural recommendations as well. Now, obviously, our organization, by amalgamating, was part of that structural set of recommendations, but also part of that gluing set of recommendations, which both David and Michael have spoken to. So maybe just to be super practical, because sometimes this can seem a little theoretical, with a couple examples of how this is changing. So I think to rewind the tape, as David suggested, to those early days in the pandemic hit long-term care really hard, as we all know. And we had been working with many long-term care homes before the pandemic, and so we heard firsthand from folks about the real challenges that they were facing with homes that had been affected by outbreaks, and for those who hadn't, about how desperate they were to learn so that they could reduce the risk for residents, for staff. And that offered an opportunity to say, can we work with CADTH to assemble the evidence? What do we know about and of course it was evolving evidence, right? It was evolving really fast. And so taking advantage of some of the new structures and processes that CADTH was putting in place to do that. To work with our friends at CADTH to be able to say, how can we leverage some of the data systems that are already in place, because the last thing anybody needed was something else on their plate, and bringing together that opportunity that our organization is focused on in terms of getting better at getting better, and how could we work together with what started with 40 homes, ended up with 1,500 across the country, to advance those proven practices. And similarly, you know, on a slightly happier note, right, early in the pandemic, virtual care was slammed in hard because it had to be. It was absolutely essential to our ability to collectively deliver health services. But that doesn't always mean it was slammed in well. And so we had an opportunity to work with our colleagues at Canada Health Infoway to learn from leaders in the space, to learn from what people had adapted and developed, to put together tools and resources that could then be used collectively across the country to help to shape the future of our use of virtual care, leveraging those learnings as we went forward. So I think there's some really practical examples of how we've been able to work together in different ways, maybe motivated by circumstances, but also informed by that foundation of the opportunities to work together.
Thank you. Suzanne.
Well, it's hard to follow my colleagues, but maybe what I would reflect on, since part of the theme of the conference is obviously health technology assessment, Fit for Purpose was really one of those moments for an appraisal of ourselves by others. It was a chance for someone to objectively look at us and hold a mirror up to us at a moment in time. Like many other things, in retrospect, the timing for that report perhaps was more important than we realized. It pointed out a lot of opportunities for us to think about how we could do better. And I want to go back to something David started off with, which was about setting aside egos. We set aside organizational barriers that had prevented us from perhaps working as closely together as we could have. You know, at the end of the day, all of us are funded in some way, shape, or form by the federal government with other contributions from provinces and territories, depending on our structure, and other income. But as a majority, we all are funded by the same people. And yet we would have conversations about who should be paying for what. During COVID, and in light of the Fit for Purpose report, it really became about how do we strategically work together. And in addition to the examples that have already been given, I think one of the things that was quite remarkable was the amount of common communication we had. Instead of single organizations having one-off conversations, we were getting regularized, very frequent early on, but have continued to be able to meet on a regular basis so that we are hearing the same information from our major funder, Health Canada. That gives us a chance to talk about issues that are arising or priorities in a way that is common. It still means that, as Michael alluded to, there are things that we do differently. We hold different parts of the system as our responsibility, but we're able to do it in a much more thoughtful way. And I think at the end of the day, it moved the conversation about pCHOs from a structural one to what is it we need to do differently together. And I think that's where we have spent at least the last 2 years of our time together.
Thank you.
Can I just add as
Please.
well, Heather? Often in the affairs of governments, you get the announcement and it looks like the problem's been solved. The sense of urgency around the stuff we're talking about has got to be relentless. We're not a whole lot better off than we were 3 years ago in some of the problems that we've just identified. So the will is there, but the continuation of the effort has to be something that's built into the fiber of our organizations.
So I would invite all of you who are involved in pressing that change to continue to do so, continue to solve these problems. So one more question for all of you, and then I'll ask specific ones. Given Shawnee's keynote address this morning, very compelling narrative for us to think differently about difference in our organizations. Can you tell me a little bit about how your organization is approaching reconciliation with Indigenous peoples, and how do you incorporate degrees of difference in the work that you do, the voices who may not have historically been present? David, I'll start with you.
So we recognized the need for ourselves as an organization to build a foundation of humility in our relationships with First Nations, Inuit, and Métis peoples and communities, and elders pre-pandemic. And so much of the work that we've done as an organization in the last 5 years has focused on awareness building, education, providing the folks who work inside CADTH with access to folks like Shawnee to talk about the lived experience of things like the residential schools experience and how it gets passed on generationally. It's not like it's ancient history. There's people my age who lived in residential schools and were subjected to the circumstances there. But it's also led to some of the insights that Shawnee mentioned about the fact that if you're building indicators, which is kind of what we do, is one of the things we do as an organization, that those indicators are being developed in the context, in a particular context. And that context is not always reflective of the people who need to be served or ought to be served or who actually have a right to be served. And just as one example, I was in a conversation with the BC First Nations health group organization, and we were talking about indicator development, and this point was being made. And the person I was talking to said, so one of the things that we use to assess the health of our communities here on the West Coast is the health of the salmon fishery. How are you going to build that into an indicator given your current methodology? So that just set off a train of awareness building and thinking that we've tried to maintain over the course of the last 4 or 5 years. We've signed on to the UN Declaration. Our relationships with First Nations, Inuit, and Métis communities and organizations gives them the control over what happens to the data and the purposes for which it's gathered and used. So we try to build all that into our programming.
Michael.
Yeah, I think at Infoway, one of the things we've tried to do is, one, raise our level of understanding of the issues that face First Nations communities. And as part of that, we have brought on 2 Indigenous members onto our board of directors. We also have teams that focus on Indigenous communities. And we've worked with leaders in the Indigenous communities to address some of the issues that they face, and also the adoption of technology kind of based on many restraints that they may have, some of which are geographical, the access to data, for example, and high-speed data can often be a problem. But I think one area that I'm quite proud of, we worked with a First Nations company called Mustimu, and together with them, they created an electronic health record that was specifically designed for their communities. And we've kind of helped support that both technically and with funding. And that system has now been rolled out in many communities across the country. And I think it's helping to provide good services, but also it's in tune with their requirements, and it allows us to kind of address some of the issues in a small way. But I think we have to continuously kind of focus, and I think our speaker earlier, Shami, kind of raised some of the issues about the nature of healthcare provision. And it is as we know, healthcare provision is a very hierarchical kind of business model, if you like. It's not really consumer-centered, even for any member of the population. So, I think that we have to be aware of, how we can kind of democratize the healthcare delivery. Hopefully, technology can play a role in providing that support as well.
Thank you, Michael. Jennifer.
So we're a new organization, and I think it's also important to recognize, while we might be a toddler organization, we're also a toddler in this work. So we are super fortunate to be guided by the perspectives of First Nations, Inuit, and Métis, and that was built in to our initial, even before we were formed as an organization, that was one of the pillars of forming the organization. And to have the opportunity to have that guidance through having been gifted a spirit bundle to our organization that has medicines and tools and resources to help us walk this path together with our partners. And we think about doing that in 3 ways. So the first, the core, the center is our Truth and Reconciliation Action Plan. That's our work to do internally of learning and unlearning and of building structures and processes within our own organization that decolonize. So for instance, that embed traditional knowledge and understandings of traditional knowledge in our understanding of intellectual property if we're signing a contract with someone. If we're doing procurement, there's a requirement that folks identify their understanding of truth and reconciliation and their commitment to it. The next layer out, building on that foundation, is our work with partners. And so we're super fortunate to have amazing partners who help to guide our work and help us to build reciprocal relationships with First Nations, with Métis, with Inuit. We have better established relationships with some groups than others, and lots of work to continue to do there. And then the outer circle is in our work with health systems to build and support the health system's muscle for cultural safety, for reconciliation. So for instance, we have a collaborative where mainstream health organizations, we support them to partner with local First Nations, Inuit or Métis, depending on where they are, and build both those reciprocal relationships that support cultural safety and also tangible, concrete actions that will affect the experience of people within those mainstream health systems and change things on the ground. So it's that sort of triple layer approach that we're aiming to take.
Well, it's a hard act to follow these three individuals. And I guess if Jennifer's a toddler, I'd say we're still getting to be able to walk in this space. That being said, I think a couple of things I would just highlight is CADTH has always had growing into the Indigenous space as something that was not just part of this strategic plan, but its previous. But like many organizations, I think it would be fair to say we got a bit lost in trying to define where it was that we were headed. And a lot of that had to do with people being afraid of being, one, not culturally sensitive enough, perhaps not learning all of the right things, and being afraid that they would do something to harm relationships further. And here in Canada, we got to a point, and it was a tragic point, where individuals such as Joyce Esserwan passing away, uncared for in a system here in Canada, that it's not raised it to our psyche again, that this isn't just about learning and reflecting, it is about action. And I think as Jennifer spoke, we've all made commitments to be able to address what needs to happen in our system to reduce the racism, improve the quality of care, and to do that in a way that isn't, as Shani described, by delivering a pool that we don't know if someone needs, but actually by listening to people. What that means for us at CADTH is we have invested in learning internally. Shani's group has been integral to that work. We've also had an initiative launched internally to recognize as settlers what it is about our organization that perhaps is unsettling and where we need to make changes. And going forward, again, still learning as we go, bringing new individuals into our organization, both individuals with Indigenous heritage, but as well individuals with a focus on diversity, equity, and inclusion, and accessibility. And as Shani said, although different, we are all talking about how do we have people's genuine and authentic voices heard in the way we develop. For CADTH, we're not yet at that third phase, that outer level of how do we start to fully embed these new ways of thinking in an important way into the HTA we do. But we are on that journey now, and one of the most significant events I've had the opportunity to participate in was just a small group conversation with four remarkable Indigenous leaders who work at different places, both within the traditional Canadian healthcare system or now Indigenous communities, and to hear firsthand how it is that we should be thinking about requests that are being made of us or to us from an Indigenous perspective.
Thank you. David, the next question's for you. We're going to go to individual questions. I encourage you to submit them, put your hand up, or submit them online, and Farrell, I'll turn to you in a minute if we have questions. Technology is moving at breakneck speed, which feels a little of a paradox given I'm reading it off of a cue card. But as we are faced with the challenges of evaluating emerging trends and the governance strategies for those, how is CADTH maintaining control, relevance in the area of things like artificial intelligence? Are there other emerging things that you're monitoring in this space, and how are you thinking about them?
Well, first of all, we're not pretending to control it, that's for sure. But I think that some of the ways that we had to behave in order to be relevant and useful, because we're basically a service provider to everybody in this room and to the people on this dais. We provide high-quality data where we can get at it for research purposes, policy purposes, health delivery program design purposes. And so we started a program about 3 or 4 years ago of developing our own internal capacity with respect to artificial intelligence through a collaboration with the University of Waterloo. And so we're training up data scientists and upskilling our own staff, but also providing insights with respect to healthcare and healthcare data back into the University of Waterloo as well, to sort of build a complementary expertise that can be self-reinforcing and shared across institutions. But I think one of the things that we need to do, this is a coincidence, this was not a Fed question, but we actually need to have a roadmap in the AI community developed, because as the holder of large administrative databases that we're reworking in order to make them available to the AI community, both the research community and the innovation community, what do we need to be doing so that CADTH doesn't become the PDF file of organizations in the next 5 years? Like, how do we respond to the needs of the artificial intelligence environment without being captive to it, in a sense? And so I expect that the same things that we've been talking about in the previous 10 minutes, collaborative networks, not making perfection the enemy of the good, and having what I would say is a principles-based, like the stuff with AI is going to exceed the capacity of legislation and regulation to govern it. So my strong feeling is that there ought to be a principles-based approach to governing the behaviors and attitudes towards the gathering and use of AI by a community of users who would sign on to principles like that. And that's one of the things that we're going to be pursuing over the next year or two.
Thank you. Many connections, I think, between your two organizations, David and Michael. And so, Michael, I don't know if you'd like to comment on that question, but I also wanted to ask you about a very recent significant success in terms of interoperability standards. Can you describe what that is for people in the audience? Why is it important?
Yes, it's a very kind of technical topic, interoperability, and it's a word that kind of people used to like to hide away from, I think, really. But I think to the real kind of issues here, and as we know, Canada is looking at interoperability between its different systems. It's an issue that faces every country, I think. And basically what we're looking at is that we're in a good position that over 90% of the family physicians have got electronic health record. And also, when you look at our hospital field, virtually every hospital has got an electronic health record either implemented or they're buying a new system and they're putting those into practice. The issue is that the hospital systems tend to be bought from 4 big American companies, and the systems that are used by family practitioners tend to have been homegrown systems that came from Canadian innovations. And those 2 different systems don't really talk together very well. And the problem, I think, as a patient is that your data may be locked in your family physician's hard drive. And so how can people get access to that data? And it really is the critical thing about data is the access to the data. And I think when we look at interoperability, I think a better way of describing it probably is connected health. And so the kind of issue that we're trying to address is the standardization and the communication between all these different systems, so that when you go and see your family physician or your nurse practitioner, that person can have access to relevant data that they need to treat you properly as a patient. And also as a patient, you want to have ability to access the data yourself, so you can be a participant in your own care. So I think the goal that we're trying to achieve together with colleagues at CADTH and other organizations and in conjunction with the provinces, territories and the federal government is to look at kind of unifying standards and look at what needs to be put in place to make sure that these systems can speak to each other, and that we do things like we eliminate the fax so that people can book appointments online, you can do e-prescribing, and you can really look at the convenience of the systems. And I think the final thing is that we often hear about physician burnout and healthcare worker burnout. And I think one of the causes of that often is the electronic health record and kind of getting to grips with some of these systems which have been relatively user unfriendly. And I think we all know that the benefit of technology really is that it should be able to simplify our work. It should be able to make life easier. It should be able to smooth processes. And I think to gain that kind of consumerization of the health system is what we're looking at. And to have interoperable systems, as we know in banking and other consumer areas, you know, that's the key really to getting the systems to work effectively together. So that's why there's a big focus on this, getting the standardization, the tools and everything out there so that all these systems can communicate and then hopefully bring our health system into the 21st century.
Thank you. My next question was going to be, and this is a little bit provocative, does this bring us up to a global standard? Are we ahead of the global standard? What's your view?
I mean, you often hear people saying Canada's in a bad shape, you know, we spend a lot of money, but we don't kind of get the outcomes. You know, I think in some areas we're a leader in the field. We were one of the first countries to kind of eliminate X-ray film, for example, but we still have a way to go. And looking at other countries, no one has completely solved the problems. And one of the key things I do believe is successful countries tend to have central leadership. And I think the great thing now is that since the pandemic and the kind of use and rise of digital health and virtual care, you know, I would say every province and territory is aware of the benefits that digital health can provide. The health minister is talking about digital health. There is a plan as one of the core pillars is to improve data access and digital health across the country. And so I think the opportunity for us is to really capitalize upon that leadership that's in place at the moment, and that will be the test. So, you know, I think the country is ready for the change, and I think it could happen quickly, and we're not badly positioned at all, I don't believe.
Thank you. So the pandemic, we're all hoping, is in our rear view mirror, but I'm going to just pause for a minute and talk to you, Jennifer, about your experiences during the pandemic. As clinicians, we know we're moved from one area to another to assist, doing things that they may not have primarily been trained to do in support of good patient care. Can you talk a little bit about your experience from a patient safety perspective and maybe what Healthcare Excellence Canada has done or supported to make our system safer?
Thanks for that, Heather. And I think I should start by saying that, you know, there's no question, if we think about long COVID for individuals, there's a long COVID tail in the health system too. Mm-hmm. And a lot of that is the impact that individuals working in the system, accessing the system are experiencing. And so our health systems are under strain. And when any system is under strain, safety becomes even more important. So, you know, we can see from the data, for instance, that rates of hospital harm are up. We can see from the data that people are experiencing silos and barriers in care. That's been true before the pandemic, but they've been highlighted and exacerbated in many ways by the pandemic. And that's not just the case in Canada. You know, I was at a global ministerial summit that WHO put on a few weeks ago, and you heard that absolutely everywhere. So what's gotten us here isn't going to get us there. And I think now we have an opportunity to really rethink safety based on what have we learned and where do we actually have the opportunity to go. So to think about how everyone can contribute to safety, to think about racism as a patient safety issue, to recognize the many dimensions of safety that we need to address. And also not just to be focused on our rearview mirror, but how can we build safer systems going forward? How can we build the capacity so that it's safe to say if you spot something, so that we can address those issues proactively rather than waiting until they cause harm, so that we can take different approaches that are likely to be more effective going forward.
Thank you. Suzanne, a question for you, and then David, I'm going to ask you a question about race-based data. Suzanne, you came in as the president and CEO of CADTH in the middle of a pandemic, and so had to run an organization virtually. Talk about some of the pain points, pressure points of coming into that role and managing an organization, given its importance during a pandemic.
Thanks for the question, Heather. You know, it's hard to actually answer a question about pain points in what you were doing when the world was going through so many pain points. But there were some really practical things. A lot of what we do and the jobs that we do are our ability to problem solve and work creatively and innovatively. There's much that can be done virtually, but there's things that were lost. Today's a good example of the fact that people do value having time together and having the opportunity to exchange ideas. But some of the challenges were also, on reflection, structurally, have we done, were we set up for success during COVID? And one of the things that really struck me was as COVID unfolded in our country, and first off, hindsight is wonderful, but we have done many things well. We have had many lessons learned. We've had people who were disproportionately impacted, but we've done many things well. But one of the reflections I have, particularly wearing my evidence hat, is what's the right structure going forward? I think we were all flummoxed during COVID by competing evidence, different provinces and territories having different guidance. Is there an opportunity for us to think about what a cross-Canada, pan-Canadian, differently informed group of experts that would include people who we recognize in hindsight were left out, whether those were patients, different types of clinicians, Indigenous communities and marginalized communities? What is it that we would want to have to enable us from an evidence perspective be able to better serve the country from a perspective of not confusing people, communicating differently, and having a place for those conversations to be prepared to have, rather than, as we saw in many jurisdictions, defaulting to a jurisdiction by jurisdiction. Some wonderful things that needed to happen, so not at all critical, but from a lessons learned, did we miss something that we could have had, particularly because of organizations that are such as those sitting on the podium today, and others that have that pan-Canadian reach that perhaps could have contributed differently.
Thank you. So far, I'm going to turn to you in 1 second as soon as I ask this question of David for an online question. So David, the questions come in from a student, and thank you to students in the room for, again, choosing CADTH as your place to come this year. If race-based data is not recorded, how would you be able to record people of color and minorities' experiences through the healthcare system? How do we understand this?
It's a great question, and thank you for raising it. It was astonishing to me how quickly this question of whether and when to gather racialized data got implemented or dealt with during the pandemic. Folks on this podium have been a part of these conversations for much longer than I have, but to me, in a data or health data organization and working closely with StatsCan, it's always been kind of a third rail conversation about whether it was acceptable practice to gather racialized data. We had a lot of expatriate Canadians coming back to Canada because they wanted, from the States, for example, where we're gathering racialized data, has provided tremendous insights into the inequities in the delivery of healthcare in that country, and there's similar challenges here. And when it became apparent that not everybody was being affected the same way by the pandemic, that racialized communities and poor communities were the ones that were bearing the brunt of the impact of the pandemic. And if you want to have realistic sense of accessibility and equity in these things, then you have to gather racialized data. And so to me, we developed a standard for gathering that data that we offered to share with other jurisdictions that was then adopted early on in the pandemic, so this sort of evidence could be informing decision making. It's an excellent question.
Thank you. Para. Can someone turn the microphone at the front, just hold it up? Okay, well, while they're sorting
I can shout.
There we go.
All right. So building on Shani's point about First Nations, Inuit, and Métis being many peoples and the challenge of representation, the question was, with whom and how should immigrant populations be engaged to ensure the health system addresses their needs? I think it feels a little bit like, how do we ensure we're not building the pool?
Was it directed at any one of the panelists in
It was
particular?
not.
Okay. So I'm going to pick Suzanne and Jennifer, please.
Go ahead.
What a great question, and I'm very proud that the questions that are being asked, particularly the last two from the floor, are being raised, which is about challenging the status quo and asking us to think differently. So I don't have an easy answer for the individual who's asked the question. What I would like to be able to say is that we will continue to find ways to reach out, identify communities differently. At CADTH, I might have believed as short as a few years ago that the only way for us to hear from patients was through a piece of paper that they would submit as part of a review of a product. I'm pleased to be able to say, we have more than a dozen, getting close to 20 different ways to bring new people into the conversations and contribute to them. But I think one of the most important things that we have learned is that it can't be a passive relationship. We need to not just be waiting for people to submit to us, in particular, whether it's a particularly rare disease, a circumstance that impacts racialized communities differently. We need to be able to go out and ask those questions of those communities in new ways that make us uncomfortable, for us to be able to gather that information. But it will be an area for us to continue to learn. And I think what I would perhaps encourage any new immigrants in this room to think about, how might we find the best people? And please feel free to share it. We would welcome that type of insight and ways of moving forward. As has been said many times before, getting it perfectly right and excellent has allowed us to stay status quo or to focus on inertia rather than boldly stepping out and trying some new things.
Thanks, Suzanne. And maybe just to build on that, Shani started us off with nothing about us without us. And I think that's a principle that's foundational. Health systems are all about people, right? The people who are involved in them in all of their different roles. And I think we also need to recognize that we all come and bring our lived experience and our lives experience. And that experience has true value in terms of understanding how not to build swimming pools, or how to adapt systems as well, whether we're building things or not, the actual lived experience of being in that health system. I think one of the other opportunities is to think in a similar way as we're thinking about, what do we need to do as organizations? What do we need to do in partnership with others, so that we aren't expecting people, to your point, Suzanne, to always come to our tables, but in fact are going to other tables and other communities? And then how can we collectively, and that's everyone in this room and well beyond, build our collective muscles and ability to do this kind of work, to take a true understanding of the differences of perspectives, and how do we embrace those different perspectives and respond to them. And again, this is an area where we are very much in the sort of early stages, holding people's hands and sometimes sitting down unexpectedly. But we've been engaging with a diversity learning exchange over the last little while that's bringing different ways of thinking about how do you connect, how do you build reciprocal relationships, and how do you move that, to a point you made earlier, Suzanne, into meaningful action. So it's not just talk, but it's the walk as well.
If you take a look at the management team at CAI, it's pretty old and it's pretty white. And so how do we expect to be able to answer these sorts of questions without actually making CAI a welcoming place for people who aren't those demographics? That they get those views and lived experience built right into the fiber of the organization.
I think you're hearing the leaders of some of our significant pCHOs tell us that change is happening already, and we're looking for more. We only have a few minutes left. We have more questions here than we'll able to get through, but I will pass them on to the panelists, and it will inform how they talk about these issues going forward. What I'd like to ask the panel members, each of you, to do is just in perhaps a minute or less, talk about what inspires you, what makes you the most hopeful as Pan-Canadian health organizations, either your ability to work together or the work you're doing as an organization. And let me start with Suzanne, please.
Oh, I'm not used to being first. I guess I would first off reflect that, in fact, the theme of the symposium gives me a lot of hope. I am an optimistic person by nature, but the fact that we're having conversations that are uncomfortable about topics that we would have never talked about at a symposium in years past is tremendously impactful for me and motivating. I think the other thing I would just reflect on, and I have team members here within the audience today, and it would be impossible to capture all of the wonderful things that are going on and all of the learning. But perhaps, the demonstrated commitment to moving us into new places in the diversity, inclusion, equity, and accessibility, in advancing our work in reconciliation, coupled with our scientific advances in real-world evidence, the innovation that is being seen, and working not just with ourselves, but working in collaboration with colleagues across Canada, whether they be pCHOs or other people in the system, but also working internationally. There is too much to be done in the health systems here and around the world for us to not use our resources and our time efficiently to collectively solve problems, rather than trying to knock them off one at a time.
Please.
Next. Okay, so we're facing some real headwinds right now, and I think the first step is acknowledging that. But the second step is to say, yeah, but we can do hard things. We will change because we have. This isn't just, a naive hope. This is evidence-informed hope. There's plenty of examples we can point to from the pandemic and before where we've tackled real tough challenges and made meaningful change. And so we now need to do that with and for more people. We need to accelerate that progress. And we need to keep our eyes on the horizon, because there will be things, whether it's AI, whether it's climate change, whether it's other things that will buffet us as we go forward. But we have the opportunity to think about how do we future-proof the directions we're going in, and that's what gives me hope and gets me excited, because of all of the people I know who are equally committed to doing just that.
Michael.
Yeah, I get inspired by seeing the solutions working in place. And, when I have had the pleasure to go and visit some pharmacies, speak to a pharmacist, speak to patients, how they see things like e-prescribing kind of improving their efficiency and also eliminating some of the errors and so on. Also visiting hospitals and talking to patients and seeing how they are benefiting from the improved technology when it's been implemented. And again, to really see these plans come into fruition, to see when you have got rooms full of experts from across the provinces and territories, all kind of working on a single direction to kind of implement improved healthcare. I mean, those are some of the inspirational things I think we can look at.
David.
I take a lot of hope and optimism from the fact that there's general recognition that none of the challenges we're confronting can be solved by any one organization, and a commitment to collaborative working to find solutions is generally accepted to be the way to go. And I take tremendous optimism from gatherings like this, where people are having an exchange of ideas and actually things are happening. Ideas get formed and they become executed. That to me gives them great, and we've seen all that in the last 3 or 4 years.
So thank you very much to our panelists today. We've heard messages of collaboration, ideas, innovation. Use your coffee breaks. Use the time you have together to identify those possibilities. Let us know how we can help and be part of that journey with you. Enjoy your coffee break. We start at 11, and again, please join me in thanking our panelists for being open to any question.